Welcome to Quality Week, May 2022. The following 4 short video presentations will provide you with insight information and personal experience on shared decision making and how it is approached from those different practitioners across our healthcare system.
Hi, my name is Suzanne Farrell. I am a consultant in anaesthetics and intensive care at Myers Hospital in Lanarkshire. I'd like to share with you for the next 10 minutes or so what shared decision making means to me, both as an anaesthetist at the start of the patient's operative journey and as an intensivist often towards the end of the patient journey. So when I've been thinking about this, what I've reflected is that shared decision making to me, it can be summed up by saying shared decision making would be the perfect patient-doctor consultation, right? So what I mean by that is, to achieve the perfect consultation, you need to have the right people at the right time and the right place, okay? And my job as an anaesthetist and intensivist is to give patients the right information to come to a decision. It's effectively where we discuss the really hard stuff, right? The what if it goes wrong. It's where we discuss what would we do if this happened. But it has to be individualised to that particular patient. So that's my role to bring. If I can elaborate what I mean by the right people is, you don't just have the patient, you have to have the next of kin. Or they can bring 2 or 3 relatives, I don't mind, as long as they bring the people that are important to them, that are going to be, that they want to discuss the making of this decision with. It can often also be a game changer in the consultation. It can change the perspective on it, and it can just change the dynamic in the room completely when you've got a relative there, sense checking what the patient is telling you. I think it's absolutely crucial. The right people also includes not just me, the anaesthetist, but ideally the surgeon as well. Now, because of timetabling and surgical commitments, that's sometimes difficult to achieve, but if I can manage it, I get the surgeon to come to the clinic too. That's the perfect scenario. If I can't make that happen, however, I make sure that I ask the surgeon the right questions in advance that are going to be pertinent to what the patient's going to ask me, so that I can give them the right information. The right time and the right place is about taking the heat out of this. This isn't about a patient that's listed for surgery. This is a patient we haven't decided one way or another whether or not they're going to go ahead. So this has to happen weeks in advance, right? So that there is no expectation set. The patient's not in day surgery in a gown with their name on a list, right? This is about actually stepping back and doing the consent process really in its fullest form, right? So I've got a clinic set up that I've managed to get a room. We can bring the patient, they see me as the intensive care specialist, they see one of my colleagues who's an anaesthetist, and ideally also the surgeon. So when I say my job is to give them the right information, what we need to do is explain risk to patients in a way that they can understand. Now, what I've learned over the process of doing this over the last 6 months or so is that actually the patient's perspective of risk is very, very different from ours as health professionals. Now, we regard anything with a more than 1% risk of death as being what we would call high risk. That's not what the patient sees at all. When you ask patients what they think the main risk to them is, they say, I think I might not wake up from the operation. Now, that's been an eye-opener for me, because actually, from my position, if we really thought that that was going to happen, that they weren't going to wake up from the operation, we wouldn't even be there having the discussion, right? So what I need to impart to the patient is not necessarily the risk of them dying, which is quite often in the range of less than 5% or 5 to 10%, but actually the risk of morbidity. Now, traditionally that's always been imparted and the consent process is kind of a list. You know, you might have a wound infection, you might have a clot in your lung, you might have a heart attack or a stroke. But I think my job is to look at the patient as an individual, find out what their health beliefs are, find out what their values are and what really matters to them with what they can do with their health. So when you say to a patient, for example, who's in their late 70s that they've got, you know, a 2% risk of death, that means nothing to them, honestly. What might be more important to them and more unpalatable is a 70% chance, for example, of landing up in a nursing home. Okay, so it's about individualising the risk for the patient and saying, listen, if you go through this surgery, we can probably get you through this surgery. Anaesthesia is generally a safe time, but what you're looking at is an uphill struggle to get back to where you are today. Then suddenly you can see the penny drop quite often. And so to me, that is one marker of a good consultation, is when the patient says, oh right, so that's what we're talking about. So that's good immediate feedback to get. Now, the penny drop moment doesn't happen every time. Sometimes the penny drop moment is realising what the risk is, but sometimes it's just about realising that actually they are party to this decision and that they are involved in making this decision. So if I give you one for example, we had a patient recently, a few months ago, who had what I would describe as significant health problems and was having probably intermediate risk surgery. It was, to my mind, the most perfect consultation that I could make, because she was there, her husband, who was her carer, was there, the anaesthetist was there, and I, as the intensive care representative, was there, and the surgeon was also there. So all the right people were in the room. She said to us at the end of 45 minutes, in your professional opinion, what do you think I should do? And I said to her, Arlene, only you can answer that, right? Only you can make that decision. It's you who lives with these symptoms. And she said, oh, right. And then there was a silence as she realised that actually we were giving her this ownership of this decision. Now at that point, the patient's husband started crying because I think he realised the enormity of what we were saying were the potential outcomes. So Graham, my colleague with whom I regularly deliver this clinic, said, oh, so we've made the relative cry, we've made the patient cry. And that's certainly not my aim. It's certainly not an aim of the clinic. However, I think if that happens, it shows you that the patient has really taken on board what you're saying, and that actually what we're talking about here is serious, and we need to think about this in all seriousness, because this is what might happen if we do this, and this is what might happen if we don't. So that I see as my job, is to distill down what matters to the patient, what this surgery might mean for them. So I have, as I say, been running the clinic for about 6 months. I've only seen 18-20 patients so far, and recently one of my registrars kindly has phoned all the patients up and said, listen, how did you feel about coming to that clinic? Did it help you reach the decision? And I've found a tool called Collaborate Questionnaire, which asks them 3 very, very simple questions, because how do I think this is valuable, but how do I know that patients think this is valuable? So the questions are pretty straightforward. They are, number 1, how much effort was made to help you understand your health issues? Number 2, how much effort was made to listen to the things that matter most to you about your health issues? And number 3, how much effort was made to include what matters to you in choosing what to do next? So I need to know that, having spent all this time, because it's very labour intensive, like we allow an hour per patient with 45 minutes to see them and then a bit of time to do the admin, I need to know that this is worth it for them, because they are, at the end of the day, our primary focus. So I've now got a checklist which goes by the acronym SURE, which I'm just using at the end of the clinic to tick off. And the SURE stands for, do you feel sure about the choice for you? Do you understand the information? So do you know the benefits and risks? So that's the R risk benefit ratio. And in E is for encouragement. Do you have enough support and advice to make a choice? So although one of these questions is, are you sure of yourself? Do you feel sure about the choice for you? I don't always expect patients to come to a decision at the end of the clinic as to whether they're not going to go ahead. In fact, I think for most patients they need a little bit more time. So I'm not looking for a decision on the day, but I am looking to know that I have given them enough information to make that decision and go away and reflect on it. So honestly, safe shared decision making is done properly, and for this patient group, high risk surgical patients, it's a win for everybody. It's a win for the patients, because my data so far has shown that after spending a bit more time, 40% of them decide not to go ahead with surgery and decide that actually what they have is better. Right? It's a win for the anaesthetist, because then on the day of surgery, when they're presented with a high risk case, there's a letter there detailing all the discussion that's been had. And it's a win for intensive care, because discussions have already been started about ventilation, renal replacement therapy, all these other potential sequelae of a big operation gone wrong. So honestly, shared decision making is a win for everybody, and I, for one, am fully signed up to it.
Welcome to a brief presentation on shared decision making and the health promoting health service. This is John's story. The concept of the health promoting health service is that every health and social care contact is a health improvement opportunity, and recognises that treatment is not the only consideration to improve health and well-being. Through the lens of the health promoting health service, shared decision making provides a health improvement opportunity. By using the Realistic Medicine 5 Questions resource in practice, this can help with collaborative conversations around what matters most to people before any test, treatment, or medicine is considered to ensure personalised care. This resource and process can help to identify and address any health behaviours and wider social and economic factors that are impacting a patient's condition and their overall health and well-being. So what does shared decision making look like in the context of the health promoting health service? Here we want to show you John's journey and the importance of shared decision making and incorporating opportunities and interventions into the process to improve health and well-being outcomes. Meet John. He is a 57-year-old man who lives alone and is currently unemployed. He smokes about 30 cigarettes a day and drinks up to 5 cans of beer every night. He was recently diagnosed with type 2 diabetes. A wee while later, John begins to feel unwell. He visits his GP complaining of headaches and dizziness. His GP identifies that he has high blood pressure and he is prescribed medication. This is the first opportunity that we have seen where a shared decision making and a health improvement conversation could have taken place. If a shared decision making conversation was had at this point, John would have been given an opportunity to discuss other options with his GP, which may have involved weight management, Quit Your Way, and alcohol-brief interventions to address potential lifestyle changes as opposed to, or in addition to, medication. This was also an opportunity for John's GP to check in with him about his understanding of his medical plan and the medication he has been prescribed. There are often barriers that prevent shared decision making from taking place, which can include health improvement conversations. These can be misunderstandings around shared decision making, where practitioners believe they already do this, but with shared decision making, we need to be listening as much as we speak to find out what is important for the patient. Or it can be a lack of confidence. Some practitioners worry that they might not have the right information or answers for a patient. For example, in a shared decision-making conversation with John, his GP would discover that John is engaging in smoking and drinking alcohol in excess that could be playing a role in the headaches and dizziness. His GP might not know who to refer him to. Within the Health Promoting Health Service, we aim to provide patients and practitioners with this information to address alternative, holistic needs that are related to the visit. This not only alleviates recurrent visits, but helps to improve the quality of life for patients and our communities. Many believe that a shared decision-making conversation is time-consuming, but research actually shows that it saves time down the road. Taking the time to have these conversations early on will not only help to improve health outcomes for our patients, but helps to improve patient autonomy and self-management over their health. Some practitioners believe that patients don't want to be involved in decision-making and mistake silence as an indicator that patients do not wish to be involved in their care plan. But it is often difficult for patients to speak up due to power imbalances. We should be encouraging our patients to consider what is important to them and listening to their perspectives. Health literacy is often a hidden issue, leading to practitioners mistakenly believing patients understand their options for care. For John, this may have been the case, and he might not have understood the importance of his diabetic medication or the medication his GP gave him for his blood pressure, leading to unregulated or missed dosage and potential readmittance. Next, in John's journey, he goes home from his visit with the GP and resumes his lifestyle of drinking and smoking in excess. A friend comes to visit and finds him unconscious. He calls an ambulance and John is taken to the hospital. While in the hospital, John is admitted to accident and emergency, where he is diagnosed as having suffered a severe ischemic stroke, and the doctors carry out a thromboectomy. While in the hospital ward, he starts to recover from his stroke and begins rehabilitation. At this point, there is another opportunity for a shared decision-making and a health improvement conversation to occur. Having a shared conversation with John during his recovery may allow for the hospital staff to identify additional needs that may reduce the chances of further ill health and improve his health outcomes. The Health Promoting Health Service is working on developing a holistic needs assessment tool to be utilised in patients' care plans to help staff identify holistic needs outside of the acute setting, with the appropriate links into services and programmes to see them through. A shared decision-making conversation may put John in touch with the appropriate services to support in his recovery and provide social support. The Health Promoting Health Service works in collaboration with Realistic Medicine to support in shared decision-making to help bridge these gaps and improve health outcomes. The first pathway we are considering is one in which a shared decision-making conversation failed to take place. After recovering in the hospital for several weeks, John returns home and begins to drink heavily. After a short spell at home, John becomes unwell. He is then readmitted to hospital. One of the reasons for John becoming unwell may have been due to the missed opportunity for a shared decision-making conversation. This health improvement conversation may have helped to identify John's lifestyle behaviours that included drinking in excess, which may impede his recovery from the stroke and managing his diabetes. If you look at the path from being admitted to hospital and being able to go home, he's having to go through that journey all over again. This is the alternative pathway in which John engaged in a shared decision-making conversation with a member of staff that helped to identify holistic needs after his stroke that could potentially reduce further ill health while helping him to make decisions about his care and recovery. Shared decision-making conversations are patient-centred and should provide the individual with all treatment options in a succinct, understandable way to allow them to make the best decision for them on an individual basis. For John, this may look like a conversation around the different pathways of care following his stroke, which could include physiotherapy, speech and language therapy, and the different medications he was prescribed. Having had a shared decision-making conversation with John's practitioner during his original admittance, together they would have explored what was important to John and identified vital elements of his lifestyle that could be impacting his health. Depending on the severity of the stroke, he may be eligible for assistance with housing, benefits, and support from carers. Being unsure of how to access these supports may be further distressing, which could also impact his health. John's journey through the healthcare system was complex without the person-centred, shared decision-making conversation. The Health Promoting Health Service supports shared decision-making by routinely opening discussions with patients, the potential for health improvement opportunities in their lives and the benefits of such opportunities on their health and well-being by means of a holistic needs assessment. By taking into account the social determinants of health, these assessments help to improve health outcomes for patients and support their clinical treatment, rehabilitation, and ongoing management of long-term conditions. The easiest route for John, and one which supports realistic medicine principles, is one in which he was at the centre of the decision-making process. Through being empowered to express his concerns and preferences to the options provided by the healthcare professional, the treatment pathway was agreed with John at the centre of the decision-making process. For more information on shared decision-making, realistic medicine, and the Health Promoting Health Service, please visit our pages. If you're interested in learning more about shared decision-making, there's a comprehensive module on SURAs available to all NHS staff.
Realistic medicine and shared decision making really go hand in hand. Realistic medicine puts the person receiving health and social care at the centre of decisions made about their care. It really needs to be sort of tailor-made to the patient, making sure it's the right treatment for the right person at the right time, delivered by the right individual. And as such, realistic medicine encourages health and care workers to find out what matters to the patient so that the care of their condition fits their needs and situation. And shared decision making very much follows on from this. As part of the pillars of realistic medicine, shared decision making is certainly one of the most important aspects of that, because within this process it really identifies the ideas, concerns and expectations of a patient that's receiving or looking to receive input from either health and or social care providers. So it is an essential part of realistic medicine. Realistic medicine itself is about supporting people to feel empowered and also to give them a conduit to allow them to be able to discuss their treatment or prospective treatments or investigations in detail. It's certainly a big shift away from the old days where sort of doctor knows best, and through shared decision making, a process between the professional and the patient, meaningful discussions about the treatment options available are had, and risks and benefits are covered. in an ideal situation to enable the patient to make the most appropriate, informed, shared decision about their health and social care needs. Shared decision making occurs when a healthcare provider and a patient work together to make a health care decision that's best for the patient, and it is very much a process, and it's far removed from situations where a patient would be given a list of options and the choice is left to them. It's, as I say, is an interaction between the patient and the healthcare professional. In this situation, the healthcare professional, granted, has the clinical expertise, but we really regard the patient as being the expert in the illness. By this, I look at a disease being the pathological process, and at the end of the day, the patient is in the best place to describe how that disease process affects them, thereby defining their illness. Within this process, various aspects of this are shared. With regards to sharing of information, this relates to ensuring that the benefits, potential harms and limitations of each treatment option are detailed, and there is also clear identification and priority of the priorities and preferences of the patient. A realistic context is set with the aspiration of providing the right care for the right patient at the right time. This is bolstered by ensuring the situation is fully understood and really identifying what matters to the patient and what type of decisions need to be made. With an effective sort of bi-directional flow of information, the decision can be reached and control and responsibility is shared between the patient and the clinician. Whilst shared decision making is expected to be a gold standard within care provision, there are obviously some certain situations or certain circumstances where shared decision making is either inappropriate or not possible. For example, in emergency situations where immediate intervention is required in order to preserve life, it's not entirely appropriate. Shared decision making should only be implemented when the patient is able to do so. In some situations, intervention may not be indicated or is not of overall benefit to the patient. Insistence of intervention on the part of, say, a family member should be explored fully, identifying the reasons for their request. An example of this would be a parent or carer insisting on an antibiotic for a viral upper respiratory tract infection. Clinicians aren't obliged to provide treatment, especially where it's not indicated. However, it is important that, again, the ideas, concerns and expectations of either the patient or their carer or guardian is explored. The other situation would be if a patient lacks capacity. It's important that the guardians or the professional looking after the patient are there as a proxy and help to hopefully identify the likely wishes of what the patient would be. In order to ensure that people are fully furnished with all the relevant facts, potential risks, potential positive and negative outcomes of any investigation, procedure or treatment, it's vital that they are engaged in a meaningful conversation. And one of the best ways of doing this is encouraging patients to ask questions. And this resource exists within NHS Lanarkshire to try and prompt patients to ask 5 relevant questions within a consultation where either treatment, investigation or provision of care is being considered. And if the patients are encouraged to ask these questions and they do so, that then facilitates a very effective shared decision-making process. What we look to do is to make sure that the patient asks, is this test or treatment essential? Is it really needed? What are the potential benefits and what are the risks? What do I stand to gain or what do I stand to lose from this? Are there any significant side effects that I need to be considered or be aware of? Is there a simpler, safer or alternative treatment option? And, very importantly, what if I do nothing? What's the worst case scenario if there wasn't any intervention undertaken at this particular point in time? A slightly simpler version of this is BRAN, B-R-A-N, and in which case we encourage people to consider, what are the benefits, what are the risks, what are the alternatives, and again, what if I do nothing? What would be the worst case scenario if there was no active intervention at this particular point in time? There are a significant number of benefits for shared decision making. It supports people to manage uncertainty, in furnishing patients with information and detailing potential benefits, harms, limitations in a language that's appropriate for them and easy to understand. We can identify patient preferences, ideas, concerns and expectation, and really personalise care. And this reduces very significantly anxiety around uncertainty. Patients requiring to make difficult decisions, often in situations where there's more than one option, may lack confidence that they're making the best decision for themselves. This can give rise to sort of internal conflict, and this can be obviated when they feel supported, with the decision-making process. There's a concept of what we call decisional regret. Patients later regret a decision that was made, thinking, did I really make the right decision? In this situation, they can often feel less satisfied with the care. And, in some instances, they may start to lose faith in healthcare providers. And again, in some situations, may actually be more likely to make complaints. Again, well-informed, supported, shared decision-making reduces the chances of this scenario arising. Taking an in-depth account of a patient's ideas, concerns and expectations certainly builds trust and makes patients far more likely to be receptive to information provided by clinician. And certainly research shows that shared decision making improves outcomes in disadvantaged and disparate populations, and thereby reducing sort of healthcare inequity. And this again is very much within the tenets of realistic medicine. It's important when we give people the various clinical scenarios, we identify risk, and we define risk as being the chance that any activity or action could happen and harm occur. It requires very effective communication of risk. It's important that we highlight the chances of how significant a benefit or an episode of harm is likely to be. And, risk itself is an intrinsic part of, a whole plethora of clinical situations, and some are very relevant at the moment. Certainly a lot of, people's mind in recent times has been, the risk associated with vaccinations, most pertinently, most recently, the COVID-19 vaccinations, and more historically, the link between, the reported potential link between vaccination and autism. Taking medication involves risk in that in mild instances there may be mild adverse outcomes. Say for example there might be GI disturbance, nausea and vomiting, but in certain situations as well, taking medication may cause very severe reactions like anaphylaxis. There may also be risk in terms of adverse outcomes in terms of side effects of known pharmacological effects. It might be ankle swelling with antihypertensives, or also impotence, again with certain antihypertensives. People undergoing treatment or procedures or investigations are very clearly potentially at risk should there be an adverse event, intraoperatively, perioperatively or postoperatively. And screening is not without its risks, is the concept of, false positives and false negatives. If somebody undergoes screening, are they made aware of the fact that the result may be a false negative, may be a false positive, they may be falsely reassured or falsely worried have been told they have a condition which they may not actually have. So risk is an intrinsic part of a lot of what we do on a day-to-day basis in all aspects of medicine, not just primary care, but secondary care as well. It's important that when we look at risk, that we communicate things very effectively. It's important that we understand the statistics that we're going to report to a patient. When we talk about anything in related to risk, it's important that we use sort of plain language and try and identify things appropriately using phrases such as low risk, things are unlikely, or there's a high chance of. These phrases certainly enable a patient to understand the situation and categorize their risk more effectively. When we look at absolute risk, there's a very effective phrase to use. It's the probability or chance of an event. It's a much easier concept to relay and for the patient to comprehend. Information framing is an important concept. In gain framing, it places a positive focus on an intervention. You know, an example of this would be, you know, regular exercise will help you lose weight, which will improve your health in general. Loss framing is the opposite of this, and it places a negative focus on doing or not doing something. Again, an example is saying to a patient, you know, being overweight increases the chance of you developing diabetes or dying prematurely. There are some merits to either, but it is always important to try and balance them out in order to sort of risk stratify properly. You know, another example would be, you know, 95 out of 100 people undergoing this kind of surgery achieve a good outcome, whereas the opposite to that would be 5 out of 100 have poor outcomes. So again, relaying information and risk is crucial. It's important that we bear in mind that frequencies are better to understand than percentages, and use of sort of common denominators. You know, say for example, you know, how many out of 100 people may be affected. It's much more easier or comprehensible to say 2 in 100 or 25 in 100 rather than 1 in 50 or 1 in 4 respectively. You know, sometimes actually throwing people graphical representation may help, but one of the things as well is be honest and be open about uncertainty. You know, nothing is clear cut, nothing is absolute, and patients often experience the honesty in expressing this. It's important that we communicate effectively within shared decision making. You know, establish a rapport with a patient, be empathetic and engage at a human level, and see things from their perspective. If you maintain a two-way conversation with the use of open-ended questions, you know, this very much promotes a very effective, you know, consultation or conversation. And the use of open and closed questions is very, very important, especially in shared decision making. You know, an example of an open question would be, you know, or the difference between the two. You know, if you ask the closed question, you know, are you worried about this? Asking that question prompts a binary response, whereas what are you worried about promotes a conversation. Language needs to be appropriate to the individual, and again promotes active discussion and helps build rapport and further understanding. And a structured approach often augments an effective communication, and an example of a defined structure to a similar conversation is the DECIDE model, the DECIDE. And when we look at DECIDE, there's various aspects to this. First of all, if we define the decision, there's a shared understanding of the situation or problem, and the ideas, concerns, and expectations are defined, and we know what the ask is. Explaining the situation removes any dividing, clarifies the situation, and paves the way for further questions or information. We consider available options, incorporating outcomes, benefits, harm, risks, or limitations. And again, recalling Bran, one option is to consider no action at this particular point in time. We can invite views. We seek input from the patient in order to help them to make a decision in a supportive way. We can put things into context, and if we identify values, beliefs with shared understanding, a shared decision can be made, and care is personalised. When we reach this decision, it can be made together, and it can be reflected upon and confirmed and reviewed to check understanding, and again reduce the possibility of decision regret. And again, we look back and again further reflect upon the decision. Again, we can say that this is the right decision that we've made together. This is the right decision for you. And whatever happens, we can both be comfortable in that we made this in the correct context in a shared manner. This has just been a very brief look at the shared decision-making process. I would just like to highlight a couple of resources that are available that describes this process in far greater detail. A very effective resource is available via TORAS, and it was the NHS Education for Scotland module on realistic conversations and shared decision making in practice. And in addition, I would like to highlight the Realistic Medicine website, because again, shared decision making, being one of the tenets of realistic medicine, is covered in great detail here. I would just like to thank you for your attention and interest in shared decision making, and hope that this information has made the process of shared decision making a little bit more understandable, accessible, and implementable. Thank you again.